And so Jason is CEO of Colorado Community Managed Care Network, a nonprofit organization governed by Colorado's federally qualified health centers. It administers population health and clinical quality improvement programs on behalf of its members and their regional partners. CCMCN is a founding member of both Colorado Access and Integrated Community Health Partnerships. Jason also serves as the co-chair of the Colorado eHealth Commission. Welcome, Jason. I will go ahead and turn it over to you.
Great. All right, I think I'm all set here. So can you guys hear me okay? Maybe thumbs up. Okay, I'm going to jump in and I've got a few slides. I'm going to kind of just talk through the healthcare side of problem solving. I think at this point, there's a lot of interesting problems to solve within healthcare. And so what I want to do is kind of introduce you to kind of the current thinking pre-pandemic and then current state. So again, I'm Jason Greer. I'm the CEO of CCMCN. I consider myself a data nerd, maybe a healthcare technologist by trade. I've been doing this for about 20 years. And so in that time space, you can imagine I've seen a lot of change within the healthcare technology space. I'm going to try to share my screen here for the second time ever. And so 1 second. Here we go. And I'm not seeing it. All right, we're going to go for the entire screen just in case. Okay. Okay, sorry about that. Okay, so I'm going to start here, and hopefully you guys can see that. I'm going to actually escape out really quick just to see the chat, just to make sure I'm still good. So, Pooja, any concerns with that? Did that work?
That's great. Thanks, Jason.
Okay, great. Thank you. Sorry about the interruption there. All right, so let's see. This is the problem that I'm trying to solve, right? So how do we use technology to improve the healthcare system for vulnerable people? This is essentially the question I've been working on for about 20 years. This is one we're still actively trying to work on today. Maybe as a way of context setting, this is where we currently are in the state of healthcare, right? So the top graph shows the level of innovation for internet technology adoption that's happening in the United States on the blue line ever since 1990 to 2013. So you see this 45-degree angle of adoption between like 1995 and like about 2006. And so other industries essentially around 2006 started innovating significantly within the internet, whereas healthcare was a little bit further behind, right? So healthcare on the bottom right graph, you can see that in 2008, that was the rate of electronic health record adoption in the country. And then on the right, in 2015, is when we actually pretty much completed electronic health record adoption in the United States. And so 2015 time that we've saturated with actually being able to access healthcare data for the first time. And so when it comes to innovation within technology and data, I'd say healthcare has been lagging behind a little bit because we've been mostly focusing on getting our digital data online. And so at this point, though, when it comes to looking at innovations in other industries, other first, second, and so we're going to now that we've got EHRs online, now's the time to start to problem solve. And so one of our first problems, I'm going to list through a set of problems that we're looking to solve within healthcare, and there's a lot of them, and there's a lot of different angles to look at them. And so one of the first ones is, why can't we shine a light on every issue so that we know where to send resources to help out? At this point, we need better data analysis. We need better information. We actually don't know what's going on across the board in lots of areas. When it comes to knowing what's going on, we need to know in a community happening with person experience, what's happening with program eligibility and enrollment, what's happening with social needs and barriers, what's the rate of loneliness and suicide and quality measures and chronic disease. We currently don't have all these things put together in a way that says, this is what normal looks like inside of a community. If we knew what normal looks like, we could point out the disparities, we could see what's happening from cost and outcomes together. We can combine that to look at impact and relationships between them, then from there we can really know kind of what's going on across every community to really be able to say for public health, for policy, and for payment. Today, this is a problem that we're solving. There's so many problems, right? So if you think about it, here's some examples of the many questions that we have that we're trying to figure out how to solve today. And so, why can't we focus on detecting cancer? Cancer detection has been a long-running priority for the healthcare system. The Bureau of Primary Healthcare is challenging us to say, why can't we health centers? What if we could improve the experience of those with developmental disabilities by creating better support systems? And at this point, families that are navigating the healthcare system and others really and are vocal about their experience with this. What if we could help more babies reach their first birthday, right? So infant mortality is a high priority for folks, and so it requires community alignment. It's a community conversation. And so infant mortality is one that we've been talking about for a long time, and we work on it in pockets, but it's not one that we can say is being worked on. And then a big one, healthcare more affordable. And so from an affordability perspective, we know that we've got the Medicare and the rising costs of Medicare. We've got the lack of predictability for Medicaid. We've got the government discussing block grants and shifting the cost onto the state. What I would start to do is to create problems within state budgets where if there's cost overruns within Medicaid, that could get shifted onto transportation and schools. And so maybe the bigger problem from a disparity perspective is around personal bankruptcy. And so what we're seeing with vulnerable residents is that healthcare is bankrupting them, creating new problems across the board. Why can't we be confident that everyone has safe water to drink, right? So we've got pockets that are popping up in Flint, Michigan, and Newark, New Jersey, other places where we don't know if we have safe water to drink or not. And so we have kind of environmental determinants as a kind of a silent problem where the patterns that we're seeing are kind of disease and death within communities, but there's not data to really help tell that story. The evidence of that to me is the EPA's kind of Superfund national priorities list, right? Where in these little dots, the yellow dots and the red dots pretty much are places where the Superfund sites are still being addressed, which to me means you don't drink the water in the yellow dots and the red dots. But this is current as of today, and so I feel like as a healthcare system, another problem to solve is we should be identifying people that live in these areas and testing their water and testing their health conditions and looking for patterns in their geographic areas, and then giving them a voice when problems occur. These kinds of problems become very politically charged as things to address. Why can't we see the impact of an intervention right away to know what works? So why can't we know today if we make an improvement in something, can we see that across the community? Well, one thing that's going on is that the payers, they want to pay based on value, and that's great, but we don't really actually know how to define value at this point. And so it's really hard to know what is value for healthcare.
Hey, Jason, I'm so sorry to interrupt.
Screening using claims data. Claims data doesn't really tell the story completely, and so the scores on the left, take the orange score, health center number 2 scored 1.5% from a claims data score. Then there's electronic health record data. We recalculated it with that, and it becomes 57.9%. The EHR data doesn't actually tell the whole story either, because that depression screening could have occurred elsewhere. And so that becomes a bigger problem within healthcare, is that what data do I trust, right? So when it comes to trust, we don't know, it's hard to know kind of what information we can trust. Information accuracy is a problem that's being worked on actively. Misinformation within healthcare is a problem. Then there's using data as a weapon against organizations for us to be problem solving today. And then organizational privacy, right? So organizations compete with each other in similar spaces, and so we need to figure out how to protect each other in the middle of becoming better with analytics. And then how do we create a better way to know what people need, right? To understanding people's needs, what we need to figure out is there's system reported processes, and then there's our needs, and then self-reported needs. And so on the system reported side, as computer people, we can know the needs of people from the outcomes of the systems, like so quality measures and KPIs and gaps in care. We can do social assessments. We know program eligibility. But we also need to know self-reported needs. We need to figure out what does somebody say that they need, what's their current behavioral health state, what's their current physical health needs and other needs that they have. And then we need to figure out how to respond to that. And so the community has to figure out how to wrap itself around the needs of the person so that we can align community organizations together, because today care isn't coordinated. And so, care within one organization can be amazing, but care between multiple organizations can be pretty segmented. And so why not just try to problem solve, one problem? So if we're getting into, let's just pick a problem and try to solve it as a group. We have inconsistent funding. We've got different priorities between organizations. For a lot of people, it feels like we're creating a disparity by choosing one problem. If we choose, experience of care over infant mortality, people believe that it's unfair actually to choose one problem over another one. And so we have typically found ourselves in a little bit of a solving problems in pockets, and then sustaining those problems is always a little bit of a challenge in healthcare, because the funding will tend to go away and the problem eventually come back. Which gets us to today, right? And so today in the current pandemic, it's been interesting, actually. So I'm 72 days in, actually here in my house, working on this problem. It's been interesting because 72 days ago, we created a shared problem. We created the problem that each of us actually have a say in, and it creates kind of a rallying effect around one problem to solve. And so while other problems still existed, a lot of us systems assess we get better conditions. And the COVID crisis itself actually kind of fast-tracked the progress.
Jason, can you hear
yep.
me? I'm sorry,
Yep.
I'm so sorry to interrupt. Your internet's getting really, really spotty. So perhaps if you turn your camera off and maybe just wrap up in a quick minute, that would be wonderful.
You got it, absolutely. And my so today. And sorry about the technical trouble.
Thank you. So Jason is joining us from the mountains, and although we double checked in rehearsals, of course, coverage can be tricky. So thanks for your patience with some of that spotty coverage. I look forward to following up on a number of those points in the Q&A.